Okay, let's talk about methylprednisone. Methylprednisolone. No, not alone. Prednisone. Prednisone. Methylprednisone. Okay. Methylprednisone is a hormone. It is also a steroid, considered a steroid. It is an analog of corticosteroid. What does this mean to us? What is it going to do? Well, its action is anti-inflammatory, and suppresses the immune system. And what indications, what things would we think of that we want an anti-inflammatory that suppresses the immune system? Where are we going to use a medication of this type? What combination of things happening could you think of for this? Well, there's many. Honestly, for the anti-inflammatory alone, there are multiple things. There are cortisone or steroid shots in the knees, in the joints, in the shoulder. There are allergy. Catalog is given for allergies, or Solumedrol, or some of those others are given for allergies and seasonal allergies for a long-term type treatment. There's multiple things in here, but let's think about it. Let's fall back on, okay, they're giving them for allergies. Why are they giving them for allergies? What happens when your allergies start attacking? You start to where you can't breathe. So methylprednisolone, which is also Solumedrol, is one of those that is able or widely used as an asthma treatment. Okay, why are we using it in asthma? What is asthma? Asthma is an inflammation and a thickening of the lining surrounding the bronchioles and the bronchus, causing airway constriction. So what can kick off asthma? Allergies can kick off asthma. Anything can kick off asthma, actually. Any kind of pollutant, any kind of anything. The body can just say, screw it, I'm just going to kick off an asthma attack. That starts swelling. If they get so far behind and they can't keep up with their albuterol inhalers and stuff like that, they may go on to a steroid treatment. They may have to take a week's worth of steroids or 3 days worth of steroids or whatever the case may be. But this is also something that we can give in the field. We are able to give this pre-hospital to kind of give that bigger step forward and less chance of hospitalization, right? So we're going to give this to our asthma patients. We can also give this to COPD exacerbation. They're having a hard time breathing. Chronic obstructive pulmonary disease. Well, asthma falls into chronic obstructive pulmonary disease. So theoretically, our 12-year-old kid or 5-year-old kid that's asthmatic also is a COPD patient by definition. So, of course, if we're giving it for asthma, we can give it for COPD. This is going to control, again, the inflammation and swelling within the lungs. Okay, and anaphylaxis. They will get a shot of a corticosteroid or something similar, or methylprednisone, or prednisone, which is the same thing, or Decadron, or another one of those steroids that has the same action, they're going to get that in anaphylaxis as well. There's a combination. They're going to get diphenhydramine, they're going to get epi, and they're going to get a steroid in an anaphylactic reaction. So how much are we going to give? We're going to give 125 to 250 milligrams, depending on local protocol. It can be given IV, IO, and honestly, it can be given IM, but we're not going to do that in the field. We're going to give it IV or IO. Would be ideal for us, because obviously they're behind the 8 ball. They're going into the hospital for further treatment. You might as well get that line going and might as well give it IV. Give it the best chance and get it moving quicker. Correct? Correct. Okay, so 125 to 150 or 250 milligrams, depending on your local protocol. Some may only want you to give 125 in the field, so then you're going to have to call, if the situation dictates you need higher dose, you're going to need to call in to your medical control, fall back on their decision. Okay? So why would we not give methylprednisone? Well, hypersensitivity. They may be sensitive to, again, the preservatives in the medication, the way the analog was synthesized, the whatever, any kind of hypersensitivity that may possibly cause an effect that you don't want. Okay, that's the only contraindication, though. Unless they just don't need it. Okay, so some of our adverse effects is GI bleeding. I don't know why I'm having trouble writing today. GI bleeding. Increases blood glucose levels. Or hyperglycemia. Now, does that mean I don't want you to give this in the instance of an asthmatic that's already hyperglycemic? No, we're still going to give it because breathing is more important than blood sugar at this point. So, you know, which one can you live with? You can live with high blood sugar. In fact, I would rather you have high blood sugar than low. But breathing is kind of hard to live without being able to do that. So let's maintain the airway, worry about the blood sugar later.